Arrhythmias that lead to sudden cardiac death. And then we also see people that develop strokes that occur from thrombosis of these left ventricular apical aneurysms, which are a very pathognomonic finding. If anybody's interested in the cardiac manifestations, there is a great talk that I believe we still have posted to our DC TrotMed YouTube channel that was given last year by Dr. Rachel Marcus, who is a cardiologist who is a national expert in Chagas cardiomyopathy. So I would encourage everyone to look at that talk. But today, I'm mainly going to talk about the gastrointestinal involvement, which gets a lot less attention. So the part that people generally agree on is that the gastrointestinal involvement occurs, that the overarching principle is that it's because of destruction of the myenteric nervous plexus that occurs over time. And then that destruction of neurons in the enteric nervous system then leads to disordered sort of progressive denervation, disordered peristalsis, where there is sphincter discoordination and increased intraluminal pressures, and which then ultimately over time leads to dilation and decreased contractile capacity, which then later in the course of illness results in these megavisceral syndromes. And if anybody who is a very specialized infectious disease physician who is looking to retrain in gastroenterology or needs a reminder, the children's literature is actually a good place to go. My kids, just out of pure coincidence, I think, asked me if they could read this book last night before bedtime, The Quest to Digest. And I was looking at the pictures and I was like, actually, this is a pretty good description of how the bolus goes via the esophagus. But as a reminder, the muscle is supposed to sequentially contract, the bolus is propelled down, and then at the bottom, it has to go via the lower esophageal sphincter into the stomach. So the part that people don't agree on quite as much, or at least that is still an evolution or better thinking of it, is how the actual neuronal destruction, how and when it occurs. So up until fairly recently, the classic view was that the enteric neuron destruction really happened during the acute phase of Chagas. And during the acute phase, they have histologic studies from the 1960s showing direct parasite invasion into the muscle tissues, lymphocytic infiltrates, and degenerative neuronal lesions. And the thought was that most of the destruction happens when the person is acutely infected, but that over time, because of unmasking, because of age-related neuronal attrition, we start to see the symptoms and side effects and radiographic changes. More recently, studies have really supported the hypothesis of the fact that it's really ongoing inflammation and progressive neuronal death that is causing a problem, in part because both correlate with the presence of Trypanosoma cruzi DNA in biopsy samples. And this idea of a mixed mechanism with progressive neuronal death because of the combination of the parasite itself and the associated immune response is really more in line with how we are currently viewing Chagas cardiomyopathy. So I think ultimately makes more sense, but I'll show you this data briefly. So this was a study where they performed esophageal biopsies on a group of controls, a group of patients with Chagas disease that did not have megaesophagus, and a group of patients with Chagas who have megaesophagus. And what they looked at was inflammation, how many neurons were present, so to what extent there was denervation, and then whether or not they could detect Trypanosoma cruzi DNA. And so I'll just take you through it. So in the control group, there were quite a lot of neurons. And you can see here on the right, virtual absence of inflammation. Then there was a group of patients with Chagas who had Chagas disease, did not have megaesophagus, and the distribution seemed to be bimodal. So there was a group of patients that still had pretty good neuron preservation, so not quite so much as the controls, but quite a lot of neurons that had almost no inflammation. And then a group of patients who did seem to have more neuronal destruction and that had a little bit of inflammation, but had not at this point in time developed megaesophagus. And then the third group of patients with megaesophagus had virtually no enteric neurons, but by contrast, had a lot of inflammation. And then they went on to look at the presence of PCR positivity on those esophageal biopsy samples. And in the control group, of course, they were PCR negative for Trypanosoma cruzi. They looked at the first group of patients without megaesophagus, the group that had the preserved neurons that did not have inflammation. And in these patients, the PCR positivity was about 50-50, keeping in mind that this is a very small sample size. And then looking at the study group that did not have megaesophagus, but did have a lot of neuron loss and a lot of inflammation, all of those patients were PCR positive. And similarly, the patients with megaesophagus were invariably PCR positive. What they didn't report on at this point is whether or not this study group, which seems like a population that might be at risk for developing megaesophagus, then later developed clinical progression. But the study is very interesting and I think supports that mechanism. So histologically speaking, here is what is going on. So let me just orient you. Box A is our control patient. So this is somebody that does not have Chagas disease. And C and D are a patient that has Chagasic megacolon. And so what we see in the control patient, there's very little inflammation in the esophagus. And what we see in Chagasic megacolon is this very intense mononuclear infiltrate in the muscle layer and the myenteric plexus. And box B is looking more at the actual neuron itself. This is a degenerated neural ganglion. So here we don't really see any inflammation around the arrow, whereas in Chagasic megaesophagus, all of these are inflammatory cells that are occurring around a degenerated neuron. And then one of the other things they've noticed is the loss of the interstitial cells of Cajal, which are sort of seen as the intestinal smooth muscle pacemakers. So in terms of looking at who develops GI involvement, the review articles are a little bit all over the map in terms of looking at the prevalence of GI involvement in patients with Chagas. What's commonly reported in review articles is that 15 to 20% have gastrointestinal involvement. But when you actually look at the literature, it's quite variable in longitudinal studies. The ranges that are reported are anywhere from 5 to 35%. And these are also mainly studies that are done in Brazil and Bolivia. And I'll get to this, but there's quite a bit of regional variation in terms of where we see GI disease. But also the issue with many of these studies is that they were really affected by different types of selection bias. And there's very sparse population-based data. It's difficult to do longitudinal studies with barium imaging in endemic community settings. And we have even less information about the colon. And then one of the other difficulties is that, again, depending on how you define GI disease, having GI symptoms is not always reflective of actually having gastrointestinal involvement from Chagas or radiographic changes. And in particular, some of the esophageal symptoms correlate very poorly with disease findings, at least radiographically, until the late stages. And again, constipation can be very poorly predictive of actually having radiographic colonic distension. So I've put up the 3 best longitudinal review articles looking at how Chagas esophageal involvement evolves over time. They're all published in the 1990s. They're all written in Portuguese, which of course I do not speak. But in terms of the actual findings, and I left it in Portuguese just because, but what they really found, so they had a group of almost 500 patients with Chagas disease that they evaluated in 1975 and then again in the year 2000. So over about a 25-year span. And patients, so what this says is patients who were normal in 1975, but developed gastrointestinal progression. And looking at the total amount, about 9.5% of patients progressed to develop esophageal disease over 25 years, whereas 84% of patients continued to have a normal esophagram. So when we look at how that progression actually numerically pans out, about a 10% progression over 25 years corresponds to a crude rate of about 0.3% per year. But keeping in mind that all of these studies were done in Brazil. So gastrointestinal disease appears to be mainly, although not completely exclusively, a disease of what we refer to as the southern cone. So if you think of, I sometimes tell the residents that my tropical medicine clinic sometimes becomes a little bit more like geography lessons. But if you think of South America as being like an ice cream cone, where here is your ice cream and here is your cone, the cone part that is below the Amazon basin is really the area that we see the gastrointestinal involvement. And what this overlaps with is of having a high prevalence of a specific strain of Trypanosoma cruzi. So we call the strains DTUs, or discrete typing units. They go from 1 through 6. And DTU 2, 5, and 6 are the ones that are really associated with having a higher chance or the presence at all of gastrointestinal involvement. So if you look at what countries these encompass, most of the studies come from central and southern Brazil, which is where we tend to see the most cases. But this area also includes most of central and southern Bolivia, this country here, which is Paraguay, the northern part of Argentina, and Chile. So that's the belt of where we see GI disease. By contrast, we think we almost never see GI disease in the TC1 affected areas, which is the predominant strain that is present in the northern part of South America, Central America, Mexico, and then also to a limited extent in the southern part of the United States. And so, so the one question that does come up though is that, is it possible that we only know about the gastrointestinal disease because most of the studies are done in Brazil, and maybe if we looked in Central or South America, we would find more? So there is one case series that was published out of Mexico where they looked at gastrointestinal symptoms and esophageal changes, and they actually did find the combination in 12 out of 71 seropositive patients. So there probably is some there, although there were some issues with the study, namely that it recruited symptomatic patients from GI clinic, and they didn't have a seronegative control group. So we don't really know if anything else was going on or what the baseline rate was in the population. And most of the esophageal abnormalities were things that were more minor. And then there have been case reports, in particular this one in a Colombian patient, where they found Chagas megacolon in patients with Trypanosoma cruzi 1. So the bottom line is the GI disease can occur outside of the southern cone, but it's probably much less common. And really, we're looking for this in patients from a series of very specific countries. So our patient was really a textbook of symptoms of the esophageal manifestations of GI disease. So he had dysphagia to both solids and liquids. Odynophagia, patients may describe regurgitation. The atypical chest pain is one that can be an early presenting feature. And of course, is often, as in our patient, patients receive a cardiac workup, but nobody thinks to really evaluate the gastrointestinal system. And in the end stage, when people develop megaesophagus, that's when we tend to see things like retained food, sometimes actually requiring endoscopies to extract food bezoars, higher risk of aspiration, and then many patients get salivary gland hypertrophy. Just to take you briefly through the grading of the esophagus, and that way you can see the radial progression. On the left, we have grade 1 esophageal disease or early esophageal disease, which is really, you see a normal caliber esophagus, but there's delayed emptying and a little bit of contrast retention at 1 minute. By the time we're getting to grade 2, you can see here, there is a moderate dilation of the esophagus, and you're seeing more retained contrast. And this is where you start to see really now uncoordinated peristalsis and some changes in tone of the lower esophageal sphincter. Stage 3, we're getting into major dilation with contrast retention, and the esophagus is starting to become hypotonic with weaker absent peristalsis. And then here is your florid grade 4 mega esophagus, where the esophagus becomes completely atonic. There's a large increase in volume, and you can see here the esophagus actually becomes elongated over the right hemidiaphragm. So obviously corresponding to the most severe disease. So, but what's interesting, and so when I mentioned that gastrointestinal symptoms don't always correlate with radiographic findings, most patients that have early esophageal involvement actually do not have dysphagia. So this was a paper that looked at symptoms and then radiographic evaluation, and found that only about a quarter of patients that had early esophageal involvement radiographically had dysphagia as a symptom, whereas it becomes very pronounced by the time you get into grade 2, 3, and 4. So it doesn't correlate early, but it does late. And then I included this one for interest, just that transit time through the esophagus really skyrockets as you go up the grades. So apparently the median transit time of through the esophagus in the control and the indeterminate phase was about 8 seconds. In early esophageal disease or grade 1, it took 5 minutes, and in mega 2, 30 minutes, mega 3, 2 hours, and then by the time you got to grade 4, it was taking 9 hours for the transit to actually occur. Okay, and then, right, so when you're doing an evaluation for someone with esophageal involvement, you have a few different modalities to consider. Usually a barium swallow is the first test, and the real role of it is to assess transit time and the diameter. But, and that's the study that is most available in endemic settings. There are some newer papers published from non-endemic settings, mainly coming out of Spain, looking at high resolution esophageal manometry, where they're actually able to detect abnormalities in peristalsis before the dilation is really evident, which makes complete sense because the denervation seems to precede the functional changes. And this actually might be a more useful modality to assess response to medical management. The role of endoscopy is really to rule out the presence of malignancy or to look for other conditions. And speaking of which, a lot of patients that have upper GI or reflux symptoms also have H. pylori. There's a very high co-prevalence and enteric parasites like strongyloides, which is present in anywhere from about 10 to 15% of patients that have Chagas disease. So, and just a reminder to not, even though you're evaluating the gastrointestinal system, don't forget the cardiac evaluation. About a third of patients will have evidence of some type of cardiac disease at the time that they present with gastrointestinal involvement. And then we think the risk of progression is somewhere between 2 to 5% per year will go on to develop cardiac issues. And again, as a reminder, this is an EKG showing a right bundle and a left anterior fascicular block, which is one of the very common EKG findings that we see in patients with early Chagas heart involvement. So now you have a patient that has mega esophagus. So what are the options in terms of doing something about it? And even though in every article they list medical treatment with things like nitrates and nifedipine, at least in the experience of our gastroenterology division, these really don't work. And so the first line management should really be some type of endoscopic or surgical procedure. The type of initial choice really depends on the combination of patient comorbidities and whether they're a good candidate for surgery, and also what the institutional experience is at any particular center. So one possibility is doing botulinum injections at the lower esophageal sphincter, which has a transient effect usually on the order of months. And then the most common procedures after that used to decrease all the treatments are really aimed at trying to decrease the lower esophageal pressure, either by relaxing it, dilating it, or cutting into it. And the options are really pneumatic balloon dilation that I'll talk about in a minute related to our patient. There is a laparoscopic myotomy called the Heller technique, where basically they make a laparoscopic incision into the lower esophageal sphincter. And then a newer similar procedure where the sphincter is, an incision is made, but it occurs endoscopically, and it's called POEM. And for really, really advanced disease, some patients need esophagectomies, although I don't really know to what extent that's still done. So our patient at Georgetown went on to receive a pneumatic balloon dilation. And so this is, I'll talk you through the pictures. So this up here on the top left is a view from just above the lower esophageal sphincter. And you can see here that all the esophageal folds are really tight there, and they form this sort of rose type shape, which is called rosetting. And it just goes to show you really to the extent that the muscle is tight. This is a classic finding in achalasia. And what they do is, using a guide wire and fluoroscopy, they advance a guide wire and they inflate a balloon. And when they inflate the balloon with contrast, what they're able to see here is something called the waist. And this is basically the lower esophageal sphincter. And the way that they know, so they dilate it to the point that they obliterate the waist. So this is the balloon after the dilation, and you can't, they've dilated it so you can't see that sort of nice hourglass shape of the lower esophageal sphincter. For the pneumatic balloon dilation, they typically use a dilator that is about 30 millimeters in width. This contrasts to the bougie procedure that he had earlier, where it was a much thinner dilation, only about 15 to 20 millimeters. So, which is part of the reason that this procedure is a lot more effective. And this really worked beautifully for him. So he was actually able, after the procedure, he was able to come off TPN. He was eating and drinking normally. He had really minimal symptoms of reflux, and he still did have the occasional transient chest pain, but nothing that really bothered him. And after that, he had some additional studies. So just based on age, he got a colonoscopy, which found a tubular adenoma. If one part of the GI system is affected, you generally evaluate the rest, and his barium enema was normal. He had a negative strongyloides IgG, and we followed his cardiac studies over time to make sure that he wasn't developing cardiac involvement, and he was okay. So this was then for a period of about 9 months, he was lost to follow-up. You'll notice the date, so in the context of COVID-19. But then he presented again early this year, again with some return of some symptoms. So it's about a year and a half later of symptom relief. But he then again developed some white phlegm, mainly in the morning and evening, occasional reflux of phlegm and food contents at night. And he would notice that when he bent down or got up quickly, he would get chest pressure. So I asked the gastroenterologist, so when you follow these patients, what's your threshold to intervene? And they said that at least for research-based studies, there's something called the Eckert score, which I've shown you here, which can help with clinical decision-making, but really it's based on whether people are having bothersome symptoms or not. So they repeated his evaluation, and what you can see here again is a moderately dilated esophagus. And this here is the lower esophageal sphincter. And you can see that there's food that is just, barium studies, that is just trickling down. So there's only a tiny little trickle into the stomach. This is from a few different angles. And it's actually, to me, looking at these pictures, it seems unbelievable that he was having as few symptoms as he did. But food apparently can take quite a long time to go down. So he was still able to eat and actually was maintaining his weight and calories. So on the basis of this, he was referred for a second pneumatic balloon dilation, and they're going to use a slightly bigger balloon up to 35 centimeters. And if that results in temporary relief but doesn't permanently solve the problem, then he will then be offered another, he'll be offered another modality. So as an example, one of the myotomies or POEM. So we've been talking a lot about gastrointestinal anatomy and GI studies, and people may be sitting there wondering, well, why haven't we heard anything yet about antiparasitic treatments? And as a reminder for the fellows, there are 2 major medications that are used to treat Chagas disease, or at least antiparasitic therapies for Chagas disease, I should say. The first line treatment is benznidazole. And even though when you read this GI intolerance rash, it seems like a rather banal set of side effects. The more experience I have had with this medication, the more I realized just how hard it is for patients to take. It's a 60-day course of treatment, so for 2 full months. It makes people feel really, really tired. Often people feel lassitude, anorexia, fatigue, they get abdominal pain. The rash is a common problem, so it happens to 1 out of every 5 patients. Usually it's mild to moderate, and it can be managed with the combination of prednisone and antihistamines, but occasionally it can be severe to the point of developing exfoliative dermatitis or DRESS. The peripheral neuropathy happens in about 10% of patients in the 2nd month of therapy, and that's up to 10%, I should say. And that's a really relevant side effect for a population that works a lot with manual jobs like various forms of construction or in some cases home cleaning. And then bone marrow suppression and hepatitis are uncommon, but this is a drug that while people take it, their liver enzymes and their blood counts need to be checked about every 2 to 3 weeks. So it's something that requires time off work and monitoring. Nifurtimox we generally view it as second line just because it has a whole different symptom or adverse effect profile that is often even more difficult to tolerate than benznidazole. Both of these drugs are FDA approved for children, and they are commercially available now. It used to be only through the CDC, but they are off-label in adults. And really the goal of taking antiparasitics in chronic Chagas disease is to prevent future cardiac disease. We don't really know if it affects the progression of GI disease, and it won't reverse anything that's already there, at least not in a way that's been proven. So when we look at the current US guidelines, which will likely be updated in the next few years, they're from 2007, looking at who needs antiparasitics. In the acute phase of Chagas, we always give it, and also for patients that have chronic Chagas who are children. In patients who reactivate their Chagas because of immunosuppression, it can also be life-saving. We generally offer it based on B3 level evidence, so compelling observational studies to women of reproductive age because we think it prevents future congenital transmission, and to patients who are indeterminate phase, so don't have symptoms, don't have cardiac findings, or that have early cardiac findings if they are relatively young. And here we consider relatively young to be under age 50 because of some observational data showing that it decreases progression to cardiomyopathy. We consider it based on C3 level evidence on a case-by-case basis for patients that are over 50 but have no symptoms. And then for people that have GI disease, but that don't have cardiac involvement, with the idea that, okay, they have gastrointestinal and organ damage, but treating with benznidazole may prevent future progression of cardiac disease because, of course, patients can have both, but there's very little evidence to support that. And then we don't give it to people that have advanced organ disease or who are pregnant. So in other words, antiparasitics most benefit people who are young and who don't have cardiac or GI involvement. So for our specific patient, this was a decision that I thought needed to be individualized. And with further discussion, we decided not to give him benznidazole. The reasons being that he was, at the time of presentation, almost 60. So he was outside that under 50 window. We don't have any evidence that it reverses or slows the progression of existing GI disease. And we have poor evidence that it will actually protect his heart within that age group and within patients that do have GI involvement. But more to the point, from a practical perspective, there were a lot of side effects. He was concerned about a lot of the symptoms. He worked 6 days a week. Taking time off work to get labs and to come to the doctor's office was something that would have been very burdensome for him. And we were also really concerned. He was a welder, so giving a welder neuropathy as a side effect, even though it's reversible, it can take a while to go away. So this could have been something that would be very morbid for him. So I will very briefly, let's see, how much time do I have, talk about the colonic manifestations. So colon manifestations typically presents as chronic, slowly progressive constipation, to the point that eventually you hear stories about people having maybe one bowel movement a week or one bowel movement every 2 weeks. Feeling of incomplete evacuation, so people manually evacuating with fingers or having difficulty evacuating stool, a lot of straining. At the end stages of megacolon, the involvement typically involves the sigmoid and the rectum, and then we start to see complications like impaction, fecalomas, and volvulus. And the way that we evaluate this typically is via barium enema. A colonoscopy is really to rule out other pathology. And a lot of patients that are presenting are usually in their 40s and 50s. So with the recent guidelines, over age 45, most patients would need a colonoscopy anyway. Interesting, the radiographic findings and symptoms are only moderately correlated. And this was something that I learned about more recently because of a patient who I saw who was having a bowel movement about every 5 days. He was from Bolivia. I was absolutely convinced he was going to have megacolon, and his barium studies were completely normal. And it turns out that even though a lot of people have constipation, it has a very poor predictive value for actually having radiographic findings. So this was a large study of about 1,200 people in Spain, almost all from Bolivia, who had Chagas disease, of which 21% had constipation. But then if you look at that 21%, only 53 of 248, so again, 21%, actually had abnormalities on the barium enema. And actually 10% of people who didn't have constipation had an abnormal enema. So it didn't have great predictive value. And of course, people and patients with Chagas can be constipated for many reasons. And one of the very common ones are changes in dietary habits compared with the endemic area. So again, my patient who didn't have constipation when I first saw him, and then all of a sudden starts complaining of needing to strain and not having a bowel movement every day. And I thought, oh, maybe he's developing GI disease, but it turns out that his new girlfriend started a job at Popeyes. So it was really a dietary thing because he was eating a lot of the food. So that's one thing to really, that's one of the more common reasons. This was, of course, you're preparing for a talk on Chagas, so you start Googling things like, how long should it take a normal person to have a bowel movement? And I think this was my favorite thing that I found. A very poor quality survey performed of 1,000 men in the United Kingdom, showing that men spend about 7 hours over the course of the year in the bathroom, predominantly to avoid household chores, having some solo time with their smartphone. And my favorite quote, 25% of men said that if they couldn't escape to the bathroom from time to time, they didn't know how they would cope. And then ironically, the people that would spend the most time cleaning the bathroom were their female partners, which I think seems inherently unfair. So management of constipation and megacolon. So all patients, it's actually exactly the same as how you would manage any other type of constipation. Increase in fluids, routine times to poop, exercise, osmotic laxatives, and then at the end stages, there are surgical procedures you can do. And one of the my day-to-day job description is not always what I would think it would be, in that I do prescribe a lot of bentonidazole now, but I think I have completely exhausted the pharmacy resources of Miralax and Metamucil. So, sometimes as an infectious disease doctor, you don't end up doing what you thought you would be doing. So I'll just end with a couple of questions. So one thing that often comes up is wondering whether we should be doing barium studies or similar screening on all patients with Chagas, regardless of whether they have GI symptoms. And the guidelines in different countries are different. In Spain, they do barium studies on all patients with Chagas, but their predominant source countries are Bolivia, Argentina, and Ecuador, where you see a lot more gastrointestinal involvement. And part of their rationale is that if you look at, in particular, the Bolivian population, 11% of asymptomatic patients have some type of major barium radiographic abnormality. In the United States, our current guidelines recommend doing barium studies only for those with gastrointestinal symptoms. But then looking at our predominant source countries, most of our patients with Chagas come from Mexico, El Salvador, Guatemala, and Honduras, where GI disease would be a lot less common, of course, except for the DC area where we see a lot of patients from Bolivia. But the rationale for not recommending it is that GI involvement would be less common, and that will it really change our management? And in most cases, it probably won't. So, and then last couple of things. So why was it important for us to know that our patient with achalasia, that it wasn't just idiopathic achalasia and that it was due to Chagas disease? A few different reasons. First, so that it gives the opportunity to evaluate and monitor for cardiac involvement, which is really, really important. It allows for the opportunity to consider bentonidazole if the person has mild or moderate GI involvement, but that has a normal heart. And then the other really important thing is that a diagnosis in one person often triggers testing of family members. And there's a really, really high odds ratio for having infected family members. The person that I saw earlier this week was diagnosed and then told her siblings about the diagnosis, and all 4 of her siblings tested positive for Chagas, which makes complete sense, of course, because they grew up in the same household and had the same epidemiologic exposures. And then last question, this was my favorite question of the week from a Georgetown internal medicine resident. I have a patient from Bolivia with constipation who has no insurance, and she thought it's important that I get this person tested. How do I test them for Chagas disease? And in the DC area, we're lucky. If someone can't afford to get a trypanosome IgG with their primary care doctor as the first screening test. Here we have the Latin American Society of Chagas, which holds free screening clinics usually on the weekends, so people can go when they're not at work at different locations in the DC metro area. And they're very easy to contact via email, phone, or website, and patients can actually just leave a message in either English or Spanish. The medical director is Dr. Rachel Marcus, who has been a phenomenal resource and advocate for patients with Chagas disease in the DC area for many years. So with that, I will end and ask if anyone has any questions. On histology, are these live organisms or dead residual antigens that drive the inflammation in esophageal disease? So it's T. cruzi DNA. It's we wouldn't normally expect it's a really good question. Usually, so in histology, you can sometimes see live organisms, but they're very sparse, and most of the time you don't. And that's true in cardiac disease as well, that if you were to take out a patient's heart or take out a patient, I mean, if a patient goes for a heart transplant, for example, with Chagas cardiomyopathy, and they do histology on the organ itself, only in a very minority of cases will you actually see the organism. So it is organism, it's parasite DNA effectively. But I don't think, it's probably not dead residual antigens. When they find it, it's presumed to be active. I don't know if anyone has systematically evaluated the answer to that question, though. Okay, I think I can see the chat. Someone said, the woman from Bogota was in all the wrong places. Oh, I can't I can't see the report that Scott sent. Okay, if that's everything, then we'll wrap up for today. Thanks everyone for tuning in. We will send out the topic of the next talk sometime soon, and we'll see everyone in about a month.